Next up, we have Robert Whittaker, who I assume is here somewhere, a familiar name to many of you. He's a science journalist hire and the author of 2 books about the history of psychiatry, Anatomy of an Epidemic and Mad in America. He's president of the Mad in America Foundation, which of course has many affiliates, including Mad in the UK. It's a non-profit organization that publishes madinamerica.com and its 11 sister sites. So we're really, really pleased that you're here today to update us on the exciting news that we all want to hear more about, the scientific collapse of the DSM's model of care. Great, over to you.
Oh, well, first of all, thank you very much for having me here. This is an incredible conference year after year. It's really amazing, and to see so many people. And I just have to say the previous talk by Kima was fantastic. So it's just a real pleasure and an honor to be here. I'm going to real quickly here. So the title of this talk is The Scientific Collapse of the DSM's Model of Care. And I want to link it to a panel that's going to happen shortly, which is, are we on the brink of change? And the answer, of course, is yes. And one of the reasons I think this is such a propitious moment is, in fact, is that the old narrative, we often think, oh, there's an existing prevailing narrative, which we've organized ourselves around, which is true. And that we have this alternative narrative that's in contrast to the prevailing narrative. But the reason this is such a propitious time for change is that prevailing narrative that we've organized ourselves around for more than 40 years has collapsed in the scientific literature. Now, maybe the public doesn't know it so much, but in the scientific literature, it's completely collapsed. That's acknowledged. And when you have the supposed scientific underpinnings of a narrative collapse, that presents a question. Well, what is the new narrative we're going to have? So I think as much as anything, we're at this incredible moment of this, what will be the new narrative that society organizes itself around? And obviously what you're seeing here at this conference is a very different narrative that is being put forward in terms of how we would think about ourselves. So here's the narrative that we have organized ourselves around for the last 40 years. It really dates back to the American Psychiatric Association's publication of DSM-3, that's its Diagnostic and Statistical Manual, in 1980. Now, there had been 2 previous DSMs by the American Psychiatric Association, but this was the moment they reconceptualized mental disorders. And by the way, Jeffrey Lieberman, the former president of the American Psychiatric Association, once said recently, I think DSM-3 is the most influential book that has been published in the last 70 years. And he didn't mean it just within psychiatry. He meant it within basically in Western society and American society. I agree with him. This completely changed how we think about ourselves, how we think about how we raise our children. It became a philosophy that we accepted as a society. So it was incredibly influential. Now, what was the core of DSM-3? In DSM-1 and DSM-2, you had an understanding that so much of mental distress, psychiatric distress, was in reaction to your environment. So environment mattered. We were people who existed in environments. There were psychological factors, et cetera. DSM-3, American Psychiatric Association, said no. These are illnesses that reside within the brain, not in your reaction to society. And they're discrete illnesses. So their schizophrenia is as different from bipolar, as different from depression, as different from ADHD, as cancer is from heart disease, okay? So we're going to be told that these are discrete illnesses within the brain. Now, they conceived of this as in 1980, and what you'll see is there was no science behind this new conception. It really was done for reasons of building up the guilds, psychiatry's image in society, which was pretty poor in the 70s. But so we hear this conceptualization, then the APA, American Psychiatric Association, set up a PR effort to sell this new story to the public and eventually around the world. And then we start hearing this. These discrete illnesses are due to chemical imbalances in the brain, okay? Now, this is a disease model. It's not a medical model, it's a disease model. It's like a bacterial model of disease. And so what do we hear? Schizophrenia is due to too much dopamine. Depression is due to too little serotonin. ADHD is due to too little dopamine. In other words, they have discrete pathological causes that reside inside you and not in the environment and your reaction to environments, okay? So that's the second thing. And by the way, this is telling of an extraordinary scientific discovery. If this is true, just think about this. The brain is so incredibly complex. We are being told that they have identified the very molecule that causes depression, causes madness, causes kids not like school. I mean, this would be, I think this would be the greatest discovery in the history of medicine if it were true. And then what do we get next? Prozac comes on the market in 1988, and we are told it fixes the serotonin imbalance, like insulin for diabetes, okay? This is the completion, in essence, of this extraordinary story of medical advance. So now you have antipsychotics that fix the dopamine imbalance. Even stimulants were marketed in the United States as something that fixed the dopamine imbalance in kids. So we had all these drugs that fix chemical imbalances. They renormalized your brain and were like insulin for diabetes. And that is a story of extraordinary medical advance. And that kicks off this extraordinary leap or increase in the psychiatrization of our society. The number of people who get diagnosed, the number of people who get treated, and also how we raise our kids, because kids start getting diagnosed as well. And by the way, the new drugs, the SSRI antidepressants, they're said to be better than the first generation of psychiatric drugs. The atypical antipsychotics better than the old antipsychotics. So that's a story of medical progress. And just to give you an idea of the expansion, the number of people today medicated for depression is 7 times higher than it was in 1990. Our spending on psychiatric drugs in the United States went from $800 million in 1987 when Prozac arrives to more than $40 billion today. That's a 50-fold increase in the market. So this is the story that happened. And by the way, the final thing is we were told that these diseases had a genetic component, okay? So everything is put into this illness model. 1980s is when it's happened. It gets sold to the public. And eventually, the majority of people come to believe it. I think in the recent paper by Joanna Moncrief, they talked about 85% of people now knowing that depression is due to low serotonin. But now you have to look. What does science show us since 1980? Because when they published 1980, their DSM-3, if you really read the book, they said, these are hypotheses. We don't really have the science to say these are discrete illnesses. So let's start with the chemical imbalance story. Where did it come from? It did not come from an understanding or discoveries of chemical problems in people so diagnosed. It came from an understanding of the mechanism of action of the drugs. So for example, researchers came to understand in the 1960s, really, that antidepressants at that time, which affected monoamine, serotonin is a monoamine. What happened is those drugs prevented or blocked the normal reuptake of serotonin and other monoamines from the synaptic cleft. That's that gap between neurons. So the way neurons communicate, you have a presynaptic neuron, releases a molecule into that tiny gap between neurons, we call the synaptic cleft, that binds with receptors on the postsynaptic neuron, and that's how the neurons pass messages along neurotransmitter pathways. But you have to have a mechanism for removing that molecule from the synaptic cleft. These have to be really rapid pulses. Serotonin goes back into that synaptic cleft, and the drugs we found kept serotonin, this is the first generation, in that synaptic cleft longer than normal, theoretically upping serotonergic activity. So that's where the so they said, aha, maybe the pathology is the opposite of what the drug does. And that was the same thing with antipsychotics. Antipsychotics block dopamine receptors. They thwart dopamine transmission. So they hypothesized maybe schizophrenia is due to too much dopamine, okay? But now, once they have that hypothesis, once they promote it to the public beginning really in the 1980s, they have to do research. Prior to going on medication, do people with depression have low serotonin? And right away, the hypothesis began to fall apart because they didn't find it to be so. As early as 1984, our National Institute of Mental Health, which is our big research agency, investigated this question, and they said it doesn't look like low serotonin is in fact a cause of depression. There was more such research done into the low serotonin theory, and in 1999, the American Psychiatric Association's own textbook said, we've investigated this hypothesis and we have not found it to be so. Now, as far as the high overactive dopamine theory of schizophrenia, same sort of thing. They investigated it. As early as 1994, John Kane, leading schizophrenia research in the United States, said, there is no good evidence for the perturbation of the dopamine system in schizophrenia. 2001, Stephen Hyman, our director of the NIMH, said, there is no compelling evidence that a lesion in the dopamine system is a primary cause of depression. In other words, really by the early 2000s, the chemical imbalance theory had been, for depression, schizophrenia, had been investigated and not found to be true. And here's 2005, Kenneth Kendler, who was a world leader in this sort of investigation of the chemical imbalance theory of mental disorders. He writes, we have hunted for big, simple neurochemical explanations for psychiatric disorders and have not found them. But what happened? Even though this theory, this hypothesis had collapsed really by the late 1990s, we kept hearing about it. Our guild, the American Psychiatric Association, continued to promote the idea. Of course, pharmaceutical companies and actually psychiatric associations, mental health organizations in other countries promoted it as well. Now, as I'm sure all of you know, Joanna Moncrief, Mark Horowitz, they published a paper, I think it was in June, that revisited the low serotonin theory of depression. They looked at all this research and said, we can't find any evidence that the low serotonin theory of depression is true. Now, that wasn't a surprising finding. What they did, though, was so comprehensive, and they also tied it to the fact that the public had been misled. And I'm pretty sure it was a pretty big deal in the UK. Unfortunately, it hasn't been such a big deal in the US. But what can we sort of gather from this whole story? A, that this central part of the disease model was false. And B, that we've organized ourselves, our thinking, around a fraudulent story. Fraudulent because once the hypothesis was found not to be true, there was a moral obligation, a medical obligation, an ethical obligation to tell that to the public, and they didn't. So that's the second thing. And I can't tell you how big a story it is if it's actually announced, understood that the chemical imbalance story was said to be dead 20 years ago, because now society can start saying, well, why were we told otherwise? Real quickly, a couple other underpinnings of this DSM model of care. That's the collapse of the chemical imbalance theory really is the collapse of that whole model. But there's other elements of the collapse. The manual itself, when you have a diagnostic manual for a profession, it's supposed to have two qualities. It's supposed to be reliable and it's supposed to be valid. Reliable means if you go to two different psychiatrists, you're going to get the same diagnosis. Valid means that there is information, scientific evidence that these are in fact discrete illnesses. Now, the chemical imbalance story would be seen as a validation of those diagnoses because they said the pathology is different. But that fell apart, so that doesn't provide validation. What are other possible validations of a disorder? A, genetic markers, they haven't been found. Biological markers haven't been found. And finally, you want to see disease-specific responses to drugs. As you know, in psychiatry, they give antidepressants for all sorts of stuff, antipsychotics, all sorts of stuff. So you do not have disease-specific drugs. Now listen to these quotes from the literature. Thomas Insel was the director of the NIMH, 2013. The weakness of the DSM is its lack of validity. It's not valid. Nancy Andreasen, former editor of the American Journal of Psychiatry, 2007. DSM diagnoses are not useful research because of their lack of validity. How about Joel Paris, McGill University was part of a roundtable in 2012 when they were doing DSM-5 and said, have these disorders been validated? And here was the conclusion. While in principle, science should be the basis of any diagnostic system, DSM has been seduced by the illusion that advances in neuroscience provide empirical validity for a new system. In reality, we do not know whether conditions like schizophrenia, bipolar disorder, or obsessive compulsive disorder are true diseases. In other words, what they're saying is this manual, which was pitched to us as a manual of validated diseases, in fact, hasn't been validated in science. And that's another element of the complete collapse of the scientific foundation for this disease model. I will also note real quickly, the genetics research hasn't panned out. I'll give you two findings from two recent studies. One, Schizophrenia Bulletin 2020 was a big study. Here's what they concluded. Social environmental circumstances, particularly childhood trauma and perceived status gap, drive most of the attributable variation in population mental health. They said the genetic risk in schizophrenia accounted for 0.5% of the risk, and that the risk by genetics for other major disorders was even less than that. In other words, it almost doesn't exist. Here's an even more recent paper, a study of 50,000 people. This was just published in 2021. They said, study of 50,000 people failed to find any genes that influence mental illness. Here is their quote. The results obtained from this study are completely negative. No gene is formally statistically significant after correction for multiple testing, and even those genes which are ranked highest and lowest do not include those which could be regarded as biologically plausible candidates. In other words, the search for genes, 40 years, has turned up nothing of importance. So we don't have a valid manual. We don't have any knowledge of separate pathologies. What we have over and over again is a story that was told to us about illnesses of the brain, diseases of the brain. That story told to the public was not found to be true in scientific investigations into it. Now, two more things. With the recent Moncrief's recent paper about, okay, low serotonin is not the cause, here's been the response by psychiatry. Well, yes, that's true, but the drugs work. Okay, and that's sort of a message to the public. Okay, maybe all these other things didn't happen, but we do have effective drugs. Well, what you find when you dug into the scientific literature again is that time and time again, you find that these medications, whether they be for schizophrenia, whether they be for depression, whether they be for ADHD, are associated with a worsening of long-term outcomes, both on symptomatology and on functioning, quality of life, et cetera, et cetera. I'll give you three key studies done by the National Institute of Mental Health that were meant to investigate longer-term outcomes in the United States with these drugs. One was a long-term study by two researchers at the University of Illinois, Thomas Job and Martin Harrow. They began their study following people admitted to two different area hospitals in Chicago, either diagnosed with a psychotic disorder or with schizophrenia. In other words, a milder psychotic disorder, schizophrenia. It's just going to be a naturalistic study. Everybody treated with antipsychotics in the hospital, they're discharged, and then they just follow them at 2 years, 4.5, 7.5, 10, 15, and 20 years. What did they find? They found that by far the best outcomes were in those who managed to take themselves off antipsychotics, and this is among schizophrenia patients, off by year 2 and stay off the drugs. The recovery rate was 8 times higher for those, long-term recovery rate for those who got off the medications. And this was the premier long-term study that the National Institute of Mental Health has funded. And they concluded that people diagnosed with schizophrenia off antipsychotic medication have significantly better global outcomes. That is our study in the United States on long-term outcomes. 8-time higher recovery rate for those off. And by the way, as part of their thing, they hypothesized maybe the reason is that antipsychotics basically cause an iatrogenic injury to the brain that makes people more vulnerable to psychosis, impairs functioning, impairs quality of life, impairs emotional response to the world. And that's the reason for the poor long-term outcomes. We had a big study of antidepressants. It's called the STAR-D study. It was the largest study ever, largest study of antidepressants ever mounted in the United States, 4,000 patients. When the NIMH mounted it, they said, this is going to be the study that guides clinical care. It's going to mimic regular clinic conditions. We're going to do everything to show that we can get people better and keep people better. It had a 1-year outcome endpoint. And here's what it produced. At the end of 1 year, of 4,041 patients who entered the study, many, by the way, with mild depression, everyone treated with antidepressants, there were only 108 people at the end of that study who were still in the study and well. That is a documented stay well rate of 3%. And then you have to ask yourself is, well, what's the natural recovery rate for depression? Because depression, prior to the antidepressant era, was always understood to be an episodic disorder. You can see research that says, oh, the 1-year recovery rate, even for hospitalized patients, is around 85%. Well, at this same time, the NIMH did do a smaller study to study the 1-year outcomes of unmedicated people for depression. And the 1-year stay well rate was 85%, just like in the old days. So you have a medicated group where hardly anyone is getting better, and a natural recovery rate that is much, much better. And even in the psychiatric journals now, they say recovery rates, stay well rates are only about 15% for medicated patients. By the way, the best long-term study now of, if you look at long-term recovery rates for schizophrenia patients in the US and other developed countries, it's now down to 5%. That's the lowest recovery rate in the 120 plus years that we've had the term schizophrenia. It's gotten worse since the 1990s, gotten worse since the 1950s. Finally, we had a study of stimulants for children. NIMH study of children, also meant to be that, well, stimulants help children over the long term. What did they find? This is for ADHD. At the end of 3 years, being on stimulant was not a marker of benefit, but of deterioration. At the end of 6 years, being on a stimulant was associated with functional impairments, greater ADHD symptoms, and higher delinquency rates. And as researchers privately confessed, they found no benefit on any domain of functioning with long-term use of stimulants. So if we really start looking at how people are affected over the long term with this paradigm of care, with this disease model of care, what do you find? You find a paradigm of care that is worsening long-term outcomes again and again and again. And by the way, that's not a surprise, because what these drugs do is they perturb, we don't have a known pathology, but what the drugs all do is they perturb normal functioning of neurotransmitter pathways. As Stephen Hyman, our director of National Institute of Mental Health, wrote in 1996 in a paper called A Paradigm for Understanding Psychotropic Drugs, these drugs produce perturbations in normal activity. In response to that perturbation, the brain goes through these compensatory adaptations. And at the end of this compensatory adaptation, the brain is now operating in a manner that is both qualitatively and quantitatively different than normal. Now, if you just think about this logically, you don't know what's wrong, you don't know what's wrong in terms of a pathology. There's no evidence that there's an abnormalcy, something abnormal physiologically. And then you give them a drug long-term that causes an abnormality. Would you really expect that to improve sort of long-term outcomes, the ability of people to sort of be emotionally engaged in life and that sort of thing? You would not expect that. So finally on this, I see my time is up. And then I'll go real quickly. All public health markers of the burden of mental illness, quote, mental illness in our society today, in the US, UK, and elsewhere, has dramatically soared since we adopted this paradigm of care. Greater number of people on disability, you have long-term outcomes worsening, we've medicated our kids, the kids now are having more trouble, our suicide rate has gone up in the United States, more and more kids are ending up in mental hospitals because they're being conditioned to think of themselves as damaged, being conditioned to think of themselves as abnormal, and you can expect that to lead more people to start conceiving of themselves as having something wrong with them as opposed to being resilient. So, and I see in the chat group, there's some people asking for some of these citations, and I can put that in the chat room in just a second, okay, to these various studies. And also just, you can find them all on madinamerica.com. You can go to drugs on the menu bar, and then there's will be a drop-down menu. You can see and have links to all these studies as well. And it's not just one study, there's multiple studies. So where are we at right now at this moment? Scientifically, the chemical imbalance story's done. It's understood scientifically that the DSM does not talk about validated disorders. The genetic search has not panned out. Outcomes are worsening, and public health burden of, quote, psychiatric disorders has gone up and up and up. So you have a failed paradigm of care. Scientifically, you have it in terms of public health outcomes. You have it in terms of individual outcomes. So that's why it's ripe for change, because in fact, the very way of thinking, the model of care we have organized ourselves around, that has collapsed scientifically. Now, the public doesn't know all that. The public is still being led to believe in the efficacy of these drugs, the importance of it, the importance of diagnosis, the validity of diagnosis. So we still have this great gap between what the science is saying and what the public is told and believes. But just to finish here, this is why this conference is so very important. It's really not about just presenting a vision of what is possible against another vision of what's possible and picking between the two. What it's really about is, how do we go forward? How should we think about these problems? What offers what is the most humanistic way forward? What offers people the best way to regain robust lives? And what should we be encouraging? Well, obviously, we just heard from the previous speaker, this whole thing about being resilient, strong, building people up, thinking of the powers we can have. So this, again, why I'm so happy and privileged to be part of this is, I see today's events not as a story, not as a exposition that says, here's an alternative view to the disease model. The disease model's dead. Didn't pan out. And now what we as a society have to do is say, well, then how are we going to think about these things? How are we going to organize our care? How are we going to help each other? And how are we going to raise our children? So thank you. It's great to be here.